All right, the history of hip arthroscopy. I like to start with this chap. He was an American. He ended up going back to Spain. But basically, George Santayana stated, "We must welcome the future, remembering that soon it will be the past, and we must respect the past, remembering that it was once all that was humanly possible." So if you can see what I'm going to talk about in such a light, I would be grateful. Because we're talking then about the history of this procedure, hip arthroscopic surgery. Well, the history of hip arthroscopy is really, in many respects, the history of endoscopy. And those of you who have been to Pompeii may realize that in the ruins of Pompeii, they found a vaginal speculum, and they also found a proctoscope. So our forefathers were looking at small holes down tubes many, many centuries before we were. But it's all about lighting, isn't it? And traditionally, I think we put up the picture of the lichlighter, and this was direct lighting, but it was a candle. And what you basically did was you put it up, generally, I think it was part of the female anatomy, you lit a candle, and really before either you or she burnt, you made a diagnosis. And that was the lichlighter, and a means of getting some lighting into a deep-seated cavity. And then here was another one. This is a form of esophagoscope. And the lighting system then was a rag soaked in turpentine, which you simply lit when you put it down the esophagus, and you had a look again before you and the patient expired. And so that was rather dangerous, as it were, having the naked flame, and so one used reflected light. And here we got one of the very early endoscopes using reflected light. But I think the guy who is probably, certainly in my view, the most important in any form of arthroscopy is this chap, Thomas Edison, the chap who supposedly invented the light bulb. Can you imagine how difficult it would be to do hip arthroscopy if we had no light? Well, traditionally, when it comes to arthroscopy, Takagi in Japan is regarded as the guy who, as it were, got us all going. But actually, not quite so true. The Danes, Severin Nordentoft, actually, I think, win. He described the word arthroscopia genu, and he was really the first arthroscopic surgeon. So Takagi did well, but he wasn't quite there first, and he was doing diagnostic arthroscopies, largely for tuberculosis of the knee, and using arthroscopes of different viewing angles. So you had a series of different viewing angles and different types of arthroscope. The physicians always have to get in on the act, and so we have a Swiss, that's Eugene Birker, and he decided that he would try arthroscopy. He did 60. He used oxygen or nitrogen rather than a liquid medium. There he is at the bottom right doing a knee arthroscopy. After 60, he decided arthroscopy was a complete waste of time, and you got a much better view with an arthrogram, and so he gave up. We had then, traditionally, we start our hip arthroscopy talks with this guy, Berman, who in 1930 went to Berlin as a fellow to learn about endoscopy, came back to the US and did a whole sequence of arthroscopic procedures on cadavers. As far as the hip was concerned, you will remember this statement as well as I. It went into the JBJS of its day, and in essence, he was saying it was a waste of time doing hip arthroscopy. He drew this picture, as you can see there, as evidence that the view was so bad that was all you could achieve, therefore don't bother to try. Now this was a time, really, where in the 1930s when people were thinking about doing minimally invasive surgery or endoscopic surgery. And so this is an advertisement from that era. So we're not new in terms of being arthroscopists. Watanabe, of course, in the mid-1950s, then starts to introduce operative arthroscopy, albeit for the knee, and that in a way is when the tidal wave begins. Well, when you think about it, each of us is absolutely daft to even consider putting an arthroscope in something like that, so tight. But it's a sort of perception, isn't it? I mean, we perceive this, don't we, as it's actually an early 20th century operating theatre. We perceive this now as being very out of date, but in its time, it was regarded as being very avant-garde. If you go to 1972 with knee arthroscopy, and look at the conclusion there. For this reason, we advocate that the technique be put into the hands of one or two individuals in a medical community. This is knee arthroscopy, okay? And you can almost hear the same being said of hip arthroscopy today. I mean, is hip arthroscopy different? Well, it is different, I think, in a way, and you may or may not be familiar with what's called the fulcrum effect. And let me sort of give this to you. Here are two pictures of snooker being played. The top end is the hip arthroscope. You have a huge length between the skin and your target, which is in the hip. It's roughly 9 centimeters, isn't it, from the skin right into the center of the hip. And so any small movement at your end gives a big movement at the other end, and it's very, very unstable. You lose that tactile sensation because the arthroscope is covered in fat and soft tissue the whole way up, the whole way along. And so that is basically what hip arthroscopy is compared to knee arthroscopy, where you have such a short distance, you can feel things much better. So there's a tactile difference between hip arthroscopy and everything else. And so no wonder it stumbled, no wonder people see it as difficult, no wonder everybody can't do it. And if you look at the history of hip arthroscopy, or in the recent times, I'm going to start in 1988 because that's when I first put a scope in a hip. You can see there have been various, as it were, peaks and troughs, but away we go. Here we are in 2015. And so I call pre-1990 the introductory period. Those of us who were doing hip arthroscopy then, what was the sort of literature? Well, they were arthroscoping dislocated hip replacements. They were taking bullets out of hips. I mean, it's a lovely thing to do. We all yearn, I think, to take a bullet out of a hip. It seems sort of very, very wary. Not many of us have done it, but a few of my colleagues overseas in the Middle East today seem to be quite expert at getting them out of hips. We've also got, is it safe to do? There you are as a young surgeon. You want to get going. Is it actually a safe thing to do? It's nice to know from Einar Eriksson in Sweden that there were no serious complications occurred. They were taking loose bodies out of the hip. They were looking at labral tears. I don't think that's a labral tear, but in the Jebaji SBR in 1988, it was regarded as one. And then we've got, in those days, simply because Jim Glick and Tom Sampson were doing it like that, the lateral approach was quite widely used. Well, I did my first hip arthroscopy. This is the X-ray of the first hip arthroscopy in 1988 that I did. It's a 52-year-old who limps in with a positive Trendelenburg gait. He's been basically climbing in the Himalaya, and I can't see anything wrong. I say to him, sir, well, I think what you need is a hip arthroscopy. I've done thousands. Of course, I've done absolutely none. I bring him in into the private hospital. I stick him on a traction table. That is my operating trolley, as you can see there, pretty archaic. And I put the arthroscope in, and that was my view. Okay, I saw absolutely nothing. I basically waved it about. I had a sort of sound rather like a sparrow passing wind, and out dropped a loose body. The patient was cured. I didn't know how I did it. He didn't know how I did it. But simply, if I hadn't had that fluke, I wouldn't be standing before you today. So anyway, you need a bit of luck to get something going. So there we are, basically, the introductory period, then into what I call the consolidation period. And we've got now Tom Bird talking about the supine approach. So we now realize you don't have to do lateral approach, you can do lateral or supine. We're talking about the arthroscopic anatomy of the hip, because if you don't know what is normal, how do you know what's abnormal? Some of us might think that is abnormal. It isn't. It's simply an ilioischial groove. It is a normal feature of a triradiate cartilage that simply hasn't come together. And then we've got complications, beginning to realize that yes, there are complications, but possibly they are within vaguely acceptable levels. And in those days, we're looking at a lot of hip scopes being diagnostic. If we look now down to the number of diagnostic hip arthroscopies now, in my own practice, it is less than 2%, or probably even less than 1% in 2015. And so we then go to the expansion period. We've now got Michael Dienst and also the French, and I think the French were probably the first, discussing hip arthroscopy without traction, describing the central and the peripheral compartments. In those days, you did one or the other, but not both. We now do both absolutely routinely. We got Brian Kelly, Mark Philippon, describing the many reasons why one did hip arthroscopy. It wasn't just simply to do with impingement. In fact, I'm totally confident that if impingement disappears tomorrow, we will still all have a healthy job. And then basically the literature, we're talking about outcomes and follow-ups. No longer are they case reports. So enter impingement, and we've got certainly NICE in the UK in 2007 publishes a report where they basically conclude that the evidence was not adequate for this procedure to be used without special arrangements for consent and for audit or research. So that was getting a number of us fairly worried in 2007. In 2008, we meet in Paris, and we have the founding of this, basically, I think, a dining club of lots of blokes who still like each other to this day, and we've got the founding of ISHA, to which you are all very welcome to join, and we would encourage you to do that, the International Society for Hip Arthroscopy. And then we then end with the diversification period. We now move into that era post-2010. Now we've got NICE doing another report, and they're now saying that current evidence is adequate for the procedure. So things have changed, and governments are beginning to become on side. We've now got prostheses being arthroscoped. We've got extra-articular surgery expanding. We've got iliopsoas being looked at. We've got peritrochanteric surgery being done. Ischiofemoral impingement, iliotibial band, sciatic neurolysis, gluteus medius. All sorts of things are going on which were not taking place as little as 5 years previously. Hip instability is now a feature, whereas before it was regarded as something eminently strange. And then articular cartilage. I mean, we all know, do we not, that the worse the articular cartilage damage, the worse the likely end result is going to be. So he who solves articular cartilage is the guy who's got the holy grail of arthroscopy. So yes, there's microfracture, but how about stem cell therapy, which is beginning to appear and to earn its place in arthroscopic surgery? And I simply show you there a layer of stem cells applied to an area of exposed subchondral bone. And then the JHPS, the Journal of Hip Preservation Surgery, open to all comers, open access, has been going for a year, leading us through to roughly where we are now. And a fantastic editorial board supporting us to the hilt. We're delighted to have them and delighted for your submissions anytime you care to send them. So if I look into the future, what do I see? Well, I see impingement. Yes, it'll always be there. I see it as being less important on our lives. I'm talking about FAI, not so much the impingements other than FAI. I see us surrounding impingement with other things. I see chondral defects still being a challenge, and us trying to answer how you get articular cartilage to grow for at least the next 5 years or more. I see extra-articular surgery as being something continuing to expand. If I was starting out hip arthroscopy to this day, this is the area I would be looking at. I see stability as being something that we now realize as being a key feature. I mean, why should the hip be the only joint which depends purely on the bony morphology for its stability? Of course it doesn't. When we talk about the shoulder and the knee, we talk about a combination of bone and shape and soft tissue. The hip is exactly the same. So stability is here to stay and will develop hugely. I see hip arthroscopy becoming more and more into the territory of the trauma surgeon. Not widely used at the moment, but certainly an area for expansion. I see children also being an area which is really up for expansion and at the moment very catered for to a very limited extent. And so if we went back to Berman, and we said to him, look, Dr. Berman, do you really think it's manifestly impossible to insert a needle between the head of the femur and the acetabulum? I wonder what he'd say. I think he'd say he was wrong. I think he'd say the sky was the limit with hip arthroscopy. We have barely started this tremendous procedure to which we all form part. Thanks very much indeed.